I found it only at 3 or 4 places. 2 was in Sikkim, one is Mangan, other was the other place. Then also in Tripura, Agartala. So once what it was in Banswara, in Rajasthan, very few places. So in this session, we will learn about periodic healthcare worker screening for TB disease and TB infection. We all know the difference between disease and infection. It was discussed yesterday. Then we had a guidelines by NTP guidelines of 2016, and then we should also know about the vaccination, means who shall be vaccinated and what are the vaccines which should be mandatory. These are the different guidelines. This is the healthcare worker surveillance for TB in India, a handbook. I think right now it is not available on the net. And these are the guidelines where which you should consult. So what is the importance of this surveillance? It is essential, it provides the data. We can know how many healthcare workers they were infected or they got the disease of TB in my institute. And if it is on a routine basis, means okay, every annual we are studying, then we can know means the mode of how much it has been transmitted, the disease, how many, what is the percentage of staff who are getting this infection of tuberculosis, and then the administrator and HICC, they should also be aware why so many people are infected in my institute. What is the problem? How it can be resolved? And all this data, it should be entered in the Nixay. So from the Nixay also you can have it. You can do the analysis. So we have got some evidences from the different studies. It was in Indian studies in Chandigarh, Gujarat, Vellore. So what they found that fourfold higher prevalence of TB among medical trainees, basically interns, junior and senior residents who are working in TB ward. Then annual risk of TB infection is 3 times higher. Then there was a control study, and frequent patient contact and working in medical wards or laboratory were independent risk factor for nosocomial TB. Then again, we allow high annual risk of TB infection among nursing students because they are the people who are mostly in contact with the patients. Then prevalence of latent TB infection is in healthcare workers is 54%. So right now our country is also going for diagnosis of latent TB infection and treatment and its treatment. So these are the studies where we found that the healthcare workers they get the infection while doing their job. And this is one study from Kerala. They studied this at the different in the different districts. And what you find the percentage of healthcare workers, it is quite high. So average is 10%. So out of 110, 10 people are infected by tuberculosis or they get tuberculosis while working in the ward or in the OPD or in the hospital. So that's why SCW surveillance is quite important. And we should go for the staff category. Means it is not only for the regular or permanent staff. It should be done for the contractual also, outsourced also, as well as those who are working part-time. At many places, part-time employees are also there. So it should cover all these type of staff, right from medical officer to security guards, health attendants, lab technicians, all staff. Means those who are engaged in the care of the patients, they should be screened for tuberculosis. This is the cascade of TB case finding. All of you know that this is the target population. In them, we must rule out the active TB. How we rule out, we will know it afterwards. So, if they are preventive TB with the different signs and symptoms, then we go for examination. Some may be diagnosed as TB confirmed, other may be no active TB. Those with TB, we should start treatment and then follow for the 6 months, or if it is DR TB, we can go for 20 months. And if there is no sign of tuberculosis, we test for the infection. We have got different methods how to test for infection. And then if he is infected, we evaluate for the TPT. What is TPT?
TB preventive
therapy. And then we start TPT, and then we also follow up the patient. So this is the cascade of TB case finding and treatment. Now we have got active screening and passive screening. What we were following initially, it was passive screening, that the patient will come on his own if he is having any symptom, if symptomatic. What is the disadvantages? It was delayed presentation. Only when I am having more of cough, then I am coming. Till that time, I am already 3 weeks delayed or 4 weeks delayed. So now the policy of government is active screening, and right now the government of India is focusing for 100 days activities at different sectors, different districts. So active screening, scheduled screening as to when and where to whom to screen. So there is a policy that you should not screen each and every population. Otherwise, it will be very much difficult to screen 140 crores of people in India. So selective population results, how the results will be reported, everything in through the next step. How those who are diagnosed will be treated, because if the diagnosis is more, we require more of medicines, we require more of treatment supporters, and records should be available. So all these active screening means every record of these people, it should be maintained in the government system. So what is the frequency and methods for screening of TB diseases in different type? Like we have got +1, +2, 3+, 4+, different category of staff. So +1, minimum contact with patient, like storekeepers. They are inside the store. The patient is not going inside the drug store. There is an entry and annual symptom screening. Most of the corporate hospitals, they also have a entry level symptom screening. In that one, we can include the screening for TB also. And and there we follow this diagnostic algorithm. Screening is done by the X-ray, and if there is any abnormal shadow in X-ray, we go for the NAT. What is NAT? It is a method of for diagnosis. It is known as nucleic acid amplification test, molecular testing. And it has got 2 types. One is the CBNAT, other is the TrueNAT. Okay. Then we have got 2+, means chances of infection, it is more. Who are treatment support officers, those who are providing treatment to the patients. Here the entry and biannual symptom screening, because they are more prone, so we go for the biannual, once in a 6 months, and the same diagnostic algorithm. These 3+ and 4+, these are the LTs, DMC LTs. NAT LT, ART centers, staff, TB test, OPD, IPD, doctors, nurses, class 4. So here again we are following entry and biannual screening, and algorithm is the same. And the 4, who are 4+, those who are working in the culture DSP lab, especially for the liquid culture lab, they are more prone, and there it should be again entry and biannual screening. So the minimum should be annual screening, and for those who are more prone, it should be the biannual screening. What are the frequency and methods? For low and medium risk, it may be done annually. For high risk setting, it can be done with biannual basis. We can use entry screening, biannual screening, symptom screening, plus X-ray. Screening it is being done by X-ray. So right now screening it is being done, but the problem is we are not having the sufficient facility for going for the chest X-ray. But in your institute, you can go for symptom screening. What is symptom screening? Sir. एंट्री स्क्रीनिंग हुआ जैसे मैं जॉब ज्वाइन करने गया आपके हॉस्पिटल में, तो उनकी पॉलिसी होती है कि जॉब करने से पहले हेल्थ चेकअप होता है, वो सारा हाँ उसका रिकॉर्ड रखते हैं। ऐसा तो नहीं कि एंट्री के टाइम में मुझे कोई बीमारी है। जैसे आप किसी कंट्री को जाते हो वीसा लेने के लिए, तो दे हैव देयर मेडिकल चेकअप। तो कफ फॉर 2 weeks और मोर, सभी को पता है। फीवर फॉर 2 weeks, basically for the pediatric TB patients. Night sweat, hemoptysis, chest pain, breathlessness, significant loss of weight. कितना वेट कम हो जाएगा तो आपको लगना चाहिए कि इसको टीबी भी हो सकता है। यहाँ तो वर्ड यूज हो गया सिग्निफिकेंट लॉस। आप लोग क्या फॉलो करते हैं जो चेस्ट टीबी से हैं? 20% तो मैं मर ही जाऊँगा। हाँ? 10 kg अप्रॉक्स। मैं 80 किलो का हूँ, मैं 10 किलो लॉस किया तो 70 किलो हुआ। ये 50 किलो के हैं, ये लॉस करके तो 40 किलो हो जाएगा। तो हमें तो कोई फर्क नहीं पड़ेगा, लेकिन इनको बहुत फर्क पड़ जाएगा। तो 10 kg तो हमारे लिए उसका कोई वैलिड रीजन नहीं हुआ। या 3 महीने पहले हमारा जो वेट था उसमें मोर देन 5% अगर लॉस होता है, so that is known as significant. हाँ बिल्कुल सर।
तो हम पेट में ये बताते हैं कि आपके कपड़े लूज अगर हो जा रहे हैं हवा से या आग में होता है, तो अगर वो लूज हो जाता है ज़्यादा तो आप समझ लीजिए आपका वेट लॉस है। हम आशा एनर्जी को ये बताते हैं कि वेट तो किसी को लेता नहीं है ट्रेंड में, तो जनरली हम ये गाइड बताते हैं कि अगर आपके कपड़े लूज हो रहे हैं तो आप समझ लीजिए कि वेट लॉस है।
वेरी गुड सर। सो ये दिस इज अ प्रैक्टिकल अप्रोच है ना। यहाँ तो हम लोग जरूरी पढ़ रहे हैं मोर देन 5% हो जाना चाहिए, लेकिन हाउ टू टेक द वेट वी कैन फॉलो इट। लॉस ऑफ एपेटाइट, उसके चलते ही वेट लॉस हो सकता है। फैटिग, स्वेलिंग इन नेक एंड एनी एब्नॉर्मलिटी इन चेस्ट एरिया। अगर हम एक्सरे ले रहे हैं और उसमें कोई भी शैडो है जो नॉर्मल है, थिंक ऑफ टीबी फर्स्ट और फिर उसका फर्दर आप टेस्ट करें। While taking history, include the following points. हमने BCG लिया था कि नहीं लिया था बचपन में? अभी एडल्ट BCG वैक्सीनेशन का भी चल रहा है in some of the districts. Past medical history and routine general examination. So हमें ये सारे चीज हमें करने पड़ेंगे। Chest radiography, it is highly sensitive, लेकिन स्पेसिफिक नहीं होता है उतना। लेकिन दूसरा पॉइंट क्या है? रिसोर्स इंटेंसिव। हमारे पास उतने फैसिलिटी नहीं होते हैं। अभी हमको लेना है 1000 का एक्सरे, इट्स वेरी डिफिकल्ट। एज DTO अगर टोल्ड कि भाई हमारे पास फैसिलिटी नहीं हो रहा है। इफ एक्सरे इज सजेस्टिव ऑफ टीबी, तब हम लोग क्या करते हैं? नेट से एग्जाम करेंगे। एंड वी शुड ऑल्सो गो फॉर TST। अगर DRT में निकलता है ड्रग ससेप्टिबिलिटी टेस्ट विद सो मेनी ड्रग्स। नाउ कमिंग फॉर द इन्फेक्शन, basically for the healthcare workers we are going for the infection part. So क्या क्या टेस्ट होता है? CY, TB स्किन टेस्ट, IGRA टेस्ट और TST, है ना। जो नया है that is CY स्किन टेस्ट। पहले IGRA था, लेकिन IGRA में थोड़ा प्रॉब्लम है, it is more costly and it's difficult to implement in the at the field level. So we are having this CY TB skin test, highly specific. It is for TB infection. There are 2 antigens, ES86 and CFP10, जो कि IGRA में भी है और since it is highly specific, the cutoff point is 5 millimeter. कितना हमारा हो रहा है? जैसे अगर हम मॉन्टोस करते हैं, तो since approx 40% of the population of the country they are infected with tuberculosis, इसलिए मॉन्टोस टेस्ट हम लोग एलर्ट में उसको हम लोग डायग्नोसिस के लिए यूज नहीं करते हैं. लेकिन यहाँ पर हम लोग कर सकते हैं कि हाईली स्पेसिफिक है. अगर 5 मिलियन से ज़्यादा हो रहा है आपका, तो यू कैन सजेस्ट कि भाई इसको टीबी इन्फेक्शन हो सकता है. इट इज कॉस्ट सेविंग. द ओनली कॉन्ट्राइंडिकेशन इज एलर्जी टू प्रोडक्ट्स फ्रॉम लैक्टोबैसिलस लैक्टेस. ये ऑफिस ऑर्डर है और एसओपी भी है रिगार्डिंग सीवर स्क्रीन टेस्ट. सो इट हैज बीन प्रोक्योर्ड एंड सप्लाइड टू द स्टेट्स. ये एक पार्ट है इसका एसओपी का. इसमें 3-4 पेज और हैं, तो उसको आप लोग देख सकते हैं. Then we have got these 3 options, TST, IGRA and CY. Both are highly sensitive. लेकिन स्पेसिफिक सबसे ज़्यादा कौन है? It is CY TB and IGRA. Ease of use requires lab and infrastructure. That is the problem with the IGRA test. इसलिए उतना सक्सेसफुल नहीं हुआ. Since 2019 लोग बोल रहे थे कि IGRA होना चाहिए, लेकिन हो नहीं पाया. This site TB test it is field friendly, और इसको आराम से अगर if we teach our field level staff, they can also read it. जैसा कि जो वैक्सीनेशन में जो लोग involved हैं, they can also read it. The cost is low, the cost of IGRA is high, and children we can also go for it. Then even with the PNHIV, we can test for the scientific test. Then what is the algorithm for TB infection screening? We have got 3 types of patients: PNHIV, household contacts of the TB patient, and other risk group. Other risk group, it includes healthcare worker also. So what you see that other risk group, they are tested for TB infection by TST or IGRA or by site TB test, and it may be negative or it may be positive. If it is negative, no headache, no problem. If it is positive, then we go for the X-ray, and if the X-ray is abnormal or normal, it will be decided by the treating physician. And then if the X-ray is abnormal, you investigate for the active TB. If there is no active TB, then we can go for the preventive treatment, if it is not contraindicated. So if there is no active TB, we can go for treatment of the TB infection. So for the treatment of the TB infection, we must rule out that there is no active TB in the patient. These are the different medicines which we are using. The most common is isoniazid. The other one is isoniazid and rifampicin, which is for the duration is for 3 months, and it's weekly 12 doses only. It is since it is for the 6 months, we have got 180 doses. So the problem is to have this isoniazid by a person who is not having any disease, but still many people they are completing the treatment. This is the newer one, isoniazid and rifampicin. It is 1 tablet daily for 28 days, 2 pills daily. So right now it is being implemented, but again means it is not available at all the places. So you can also go for thrice 3 months duration. One tablet, 3 pills in means 1 week. So 3 months it is going for 12 doses. Pregnant woman, isoniazid is safe, but this is, still it is not known that whether it is safe in pregnant woman or not. So it is not being used in the pregnant woman. Which drug is first line TB drug is not being used in pregnant woman? First line drug. We have got 5 drugs which are JDS. So which is not safe? except from IC, we don't give. Okay. Then once we have done the surveillance, at many places we don't keep the records. At two places I found that they were having a record for this, they have done the IGRA of all the staff, and it was there in